This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast, April 2026. Ryan, how you doing?
Doing amazing down here in New Zealand.
Yeah, you're back home. Weren't you away last month, or was it the month before that you were away?
Yeah, sometimes in Australia, but no place exotic.
Yeah, I thought you were back in the U.S. for a little while.
Well, going there this month, though.
Okay, cool. All right, maybe we'll meet up.
Informatics conference in Denver if anybody else is going.
That is exciting. All right, well, why don't we jump in?
We'll get right into it. The first article we'll talk about in this episode is called Cumulative Instance of Stroke, Disability, and Mortality Following Emergency Department Discharge for Dizziness, a cohort study. Our lead author here is Kevin Kerber, and they are at The Ohio State University. Dizziness in the emergency department has been a topic of discussion far exceeding the problematic nature of its evaluation. No one likes to see someone who's quote-unquote weak and dizzy. But likewise, we haven't been leaving a trail of chaos and disability by virtue of our baseline unstructured evaluation. We've previously discussed the low instance of short-term stroke in patients discharged from the emergency department, and this is another look at this sort of data. But even better, uses in-depth electronic health record data to look under the hood at the consequences of the few strokes that are missed. This is a Kaiser Permanente Southern California cohort, and these authors poll 77,000 ED dizziness visits discharged home. Of these, 94 suffered a stroke hospitalization within 30 days. That is 0.12%, or 1 in 830. Of those, only 33 were classified as having persistent disability or death, although there were another 13 in the so-called without disability of death cohort with a modified Rankin scale of 4, although some of these scores are imputed from other clinical data. The authors basically go on, though, to conclude the cumulative incidence of stroke after an ED visit for dizziness is low, and the incidence of serious morbidity is even lower. So, there are really two issues relevant to the specious calls for further investment in stroke-related diagnostic error in the emergency department. Teasing through these data even further, only about half of these revisits occurred in the first 5 days, the most plausible cohort for a potential quote-unquote missed diagnosis on the first visit. Then, the cohort suffering strokes within 30 days were mostly in their 60s and 70s, frequently known to have diabetes, hypertension, and vascular disease. They already have an elevated actuarial baseline for an unrelated cerebrovascular event within a 30-day window for a visit to the emergency department for some sort of acute illness. The authors note some of these issues, and with respect to further investment into the problem, that serious outcomes are so rare, it would take hundreds of thousands of patients in a study to show a significant reduction in patient-oriented adverse outcomes, and is almost guaranteed a screening or diagnostic aid will generate more false positives than true positives. Just don't get caught up in this dizziness hype. Keep doing your typical sound clinical assessment, and don't do plain CTs in patients with isolated dizziness.
It always amazes me is how out of line the literature was the fear of missing strokes with isolated dizziness. Because we've done this topic many, many times on this podcast. Each time the risk of missed strokes in whatever we're doing is incredibly low. And you're right, is there any way you could actually create a lower rate of missed strokes without creating all kinds of false positives and so forth? I don't think there is. And so it is pretty interesting that it's such a big fear. People hate it. People don't feel like they can clinically assess it. And yet, all the data suggests we're doing a pretty good job.
Yeah, I mean, we've got to the point where part of it, I think, comes from the stroke industrial complex, and whereas if you've missed a cerebellar stroke, it comes back down through quality improvement committees and you get nasty grams. So there's always that, I don't want to send home a stroke because I don't want to hear about it, as opposed to I'm worried I'm going to miss a tiny stroke in the cerebellum. And that, of course, it all comes from the research in that AHRQ report and a few tiny case series in Corpus Christi, where some people were admitted for dizziness and it turned out they had a stroke. It does happen, but it's just so vanishingly rare that we're going to invest so much money in these few missed cases that it's just not worth it.
I think the other thing is there was been a movement for probably the last decade or so that we're doing dizziness wrong and have made it a very complicated disease process that I think intimidates most emergency physicians. And so, there's this kind of fear that we're going to miss it and we don't have the clinical acumen to actually assess it. But most of the data suggests we're doing just fine. I think the big thing that you said, probably the biggest yield we could do is stop doing head CTs on people that just have isolated dizziness. Because either you need the MRI or you need nothing, right? It's usually one or the other.
Well, I'm sure we'll have another study for this sometime in the next year.
Well, every year. All right. Our next study is arterial Doppler ultrasound blood flow waveforms during chest compression to detect arterial line pulsatility. And the lead author is Daniel Rolston at Northwell Health in Long Island, New York. The premise of the study is somewhat simple, but every time you pause CPR for a pulse check, we lose somewhat of our perfusion pressure. And there is some evidence that talks about chest compression fraction, and the higher the chest compression fraction, the better the patient's outcome. And so what these authors wanted to look at is, can they use femoral Doppler during active compressions to tell us whether a patient has a pulse before we stop? They did a prospective study looking at adult patients in cardiac arrest that presented to the ED from 2019 to 2024. Now, this is important to note. All these patients had femoral arterial lines in place as their reference standards for having a pulse. So a pretty specific population. And they had a Doppler trained attending who was available during the arrest. Before each pulse check, the sonographer basically obtained an image of your femoral artery, placed a pulse wave Doppler over that femoral artery, and got basically a Doppler signal during the cardiac arrest and took photos of it. This was then sent to independent reviewers who were blinded of the actual outcomes of the cardiac arrest. And they basically classified these waveforms into 4 patterns. First was bidirectional flow, so flow going away from the heart and back towards the heart, and they had to have each with velocities that were about 20% of each other. So they couldn't be too exaggerated in one way or the other. And essentially, the way they viewed this was no net forward flow. You were getting blood flowing back and forth, essentially the same amount. So no intrinsic contractility. The second one was minimal flow. Basically, there wasn't really anything happening. Your peak flows were below 20 centimeters per second in both directions. And again, that's this poor compression, stagnant blood, no intrinsic cardiac function. The next was antegrade dominant. So most of the flow was going in the forward direction, and it was exceeding 20% of whatever other flow was going in the other direction. And this, they thought, suggested cardiac contractility, tipping the balance into forward flow. And the last one was pulsatility through compressions. So this was visible Doppler signals that would look like actual arterial Doppler signals that was happening independent of the CPR. And what they hypothesized was the first 2 patterns, so the bidirectional flow and the minimal flow, basically predicted no cardiac function. And the second 2, antegrade dominant and pulsatile flow, predicted that the patient had actual intrinsic contractility at that point. So overall, they had 44 patients with 123 waveforms during pulse checks. This population was pretty similar to what we see in out-of-hospital cardiac arrest making it to the ED. Elderly, non-shockable rhythms, 52% PEA, 25% asystole. Only 36 of these patients achieved ROSC. They report a diagnostic accuracy of 88%, basically saying the sensitivity for antegrade and pulsatility flow to detect compressions to detect contractility or intrinsic contractility or ROSC through compressions was 97%, which is pretty good. And the specificity was 81.5%. If you dive a little deeper, because that seems pretty good, when you look at the pulsatility waveform through compressions, the median systolic blood pressure in the patients that did actually have cardiac function was 71, and 72% of these people had a systolic blood pressure over 60%. Now, if you look at the antegrade flow, the median systolic blood pressure was only 40, and only 23% of these patients had a systolic blood pressure over 60. So this is speaking to, while they both predicted the heart was beating, certainly the pulsatility group had a lot more cardiac function and produced a lot more of a pulse than the antegrade flow did. What do we do with this? I think it's somewhat interesting. I think, neither one of these things predicted someone with great cardiac function. I'm not sure exactly what to do with this. I'm not sure it really helps more than taking a good look in the heart and seeing if you have any good cardiac function. I think a lot of these patients, once you've made it to the emergency department, without ROSC, the likelihood that you're going to have survival with good cardiac outcome is fairly low already. So how much of this work are you actually going to do? But I think with a few more studies, maybe some comfort here, at least the pulsatility, the pulsatile waveform does show some promise at identifying a pretty good contractility.
Yeah, I mean, this is basically, exploratory pilot work. It's a cool application. It's an interesting idea, and it's just 100% not ready for prime time. Maybe not even at the facility where they're doing the study. If it, it's hard to compare, but in their limitations section, they go up to it's like what, first, second, third. They go up to 10th. They're like listing all these possible limitations of this study. So the study has threats to internal validity. I don't see any possible external validity or generalizability to it yet. But hey, this is just 2026, and maybe in 2030 or 2036, we'll have little itty bitty devices that you just slap on the femoral artery, and it tells you whether you're doing appropriate compressions. It gives you a green when you can stop compressions because there's enough forward flow. Who knows? But this is the very first level, very first of the steps in doing that sort of thing, exploring that sort of application. So I'm fine that this isn't ready for clinical use. It's its first step.
Indeed. All right, let's move on.
And the next article we'll talk about is called The Limit of Detection in the Emergency Department Trial, Legend, a stepped wedge cluster randomized trial to rule out acute myocardial infarction and reduce hospitals' length of stay for patients presenting to the emergency department. Lead author here is Jamie Greenslade, and they are at Royal Brisbane and Women's Hospital. This is a bit of a funny article because it depends so greatly on the local model of care for chest pain in the emergency department. In the emergency departments included in this study, out in Queensland, Australia, admission rates for chest pain are still in the 30 to 40% range, and ED length of stay is over 7 hours. So you can already see what we're up against. This study, then, was a push and a follow-up report on what would happen if an attempt was made to discharge from the patients from the emergency department if they had a non-ischemic ECG and their initial high-sensitive troponin measurement, at least 2 hours from pain onset, was below the limit of the assay detection. And to some extent, this works. In their stepped wedge rollout of this intervention, emphasizing education of hospital staff, the research team basically went around and told them to stop using worthless stress tests in low-risk chest pain and just discharge these super negative troponin patients. And so all is well. With 1,300 in the standard care and 1,300 in the intervention cohorts, ED length of stay dropped from 7 hours to 5.5. They even managed to discharge 40% within 4 hours, as opposed to a mere 18% from before. And yes, within 30 days, this cohort had infinitesimal event rates. 4 patients out of this cohort had events. 2 at the index visit who probably shouldn't have been included due to abnormal ECGs, and 2 within a month, one of whom presented during an abnormal outpatient follow-up stress test. So, long story being short, doing safe things is safe. And then these are just still mind-bogglingly long ED lengths of stay for non-ischemic troponin-negative chest pains. This study and its outcomes might generalize to other facilities in Australia or Southeast Asia where other services copy this model of care, but otherwise this ought to be a pretty straightforward lesson in doing one test should be faster than doing more than one test. I also find it a little bit odd, generally speaking, when a study is conducted and takes 5 to 6 years to get published. It has been a little eventful since 2019, but it still just makes me always wonder a little bit when something just can't seem to find its way into the published literature for that long.
Yeah, I mean, maybe that's it. Maybe it's just that this was done in 2019. But the first time I read this, I was like, I thought we were doing this already. Like, what is the standard care grouping? I think this was like, when your high sensitivity troponin comes back as below the level of detection, it's a gimme. Like that's the easy one. And so I was a little curious on the point of this study. Maybe it was just that there was that 6-7 year delay, and I just don't remember what was happening back in 2019 compared to now.
I mean, it feels a little bit like it's back in like 2010, 2012, like at the peak sort of ED chest pain observation unit medicine, where everybody with chest pain stuck around overnight to get a MUGA scan or a stress test or what have you, or then a CT coronary angiogram, so maybe they're still in that sort of model of care. But yeah, they got to get these patients out of the hospital.
Yeah, and the inpatient admission rate wasn't really that much higher in the standard group, and most of their win was because they created this 4-hour discharge within 4 hour endpoint, which obviously the intervention group did much better. But all in all, I think we've had pretty good data for a while that if you're below the level of detection, you can send the patients home. I guess this is just a good example of, if you teach people to do that, they will do it more often.
It's basically a cultural change. It's like it's a how can we encourage people and then reinforce that for people that it's going to be safe. So it's an education intervention more than a technology intervention here.
Yeah. Shall we move on?
Mhm.
Our next article is Outcomes Associated with an Age-Friendly Emergency Department Intervention. The lead author is Julia Adler-Milstein from UCSF Health in San Francisco. We all have many older patients that visit our emergency department, and I think we're all fairly aware that admitting older patients to the hospital tends to have a lot of unintended consequences from the hospitalization itself. So what they wanted to do was to see if a structured geriatric assessment delivered in the emergency department could safely prevent admission for more of these elderly patients. And they conducted a quasi-experimental study over a 3-year period where essentially they conducted a comprehensive geriatric assessment that was delivered by a nurse practitioner with geriatric and outpatient experience, where they looked at cognitive, functional, and social screenings, reviewed charts, reviewed their medicines. They did a bedside evaluation, contacted the family, the primary care provider, and just basically collated all this into whether this patient could be safely discharged. Now, note, they didn't actually make disposition recommendations. They just talked to the ED team about what they thought and what they found and let the ED team make their own assessments. There was 2 other optional interventions that could be added, which was social work and focusing on community-based resources and health-related social needs, and then clinical pharmacist, which looked at medication reconciliation and high-risk prescribing. The control group basically were the same patients that met all the same inclusion criteria, but they didn't receive any of these interventions. Now, but this is an important note. This wasn't randomized. This wasn't, odd and even day. It was typically just the patients who weren't seen because the NP that day didn't have capacity, or some other reason that the patient wasn't evaluated for this intervention. They then looked at hospital admission, ED length of stay, 72-hour revisits, and 30-day revisits. So overall, they looked at a little over 2,700 patients. A little over 1,100 received this geriatric assessment, and 1,600 or so were the controls. The intervention group was older, more likely to be female, more likely to have limited English proficiency, and slightly less ESI scores. Overall, what they found was when you did this geriatric assessment in the ED, there was an 11.6% lower likelihood of admission to the hospital. And this seemed to be consistent across all age groups, including the oldest, across all sexes, English proficiency, so on and so forth. They also found no significant difference in ED lengths of stay, no significant increase in 72-hour revisits, and no significant difference in the 30-day revisits as well. It's also worth noting when they added the social work to the modified geriatric assessment, there was actually an increase in the reduction to admissions to 25%. But when they added the pharmacy intervention, they actually were associated with higher rates of admission and longer ED stays. So overall, I think this is an interesting concept. I think the big flaw here is it not being randomized or not, being allocated in a specific way. This obviously introduces a ton of bias and why some patients got it and other patients didn't. But we've done many studies like this in the past. And when you provide people with more capacity to follow up, more idea of their infrastructure at home and whether it is safe to discharge, we typically see you can end up getting more patients out of the hospital.
Yeah, and there's lots and lots of research that shows that we probably admit way more older patients to the hospital who could probably be cared for in their own homes or in their facilities with the proper support and the proper follow-up. This is obviously a huge investment in your emergency department into this, and I wouldn't read much into like whether the nurse practitioner thing decreased admissions, but pharmacy increased admissions and all those sorts of things. There's all sorts of selection bias, and it's not randomized who gets what, and there's obviously a clinical reason why these patients had pharmacy involved and why they were actually sicker than the patients who didn't have pharmacy involved, and so on and so forth. So it's great they're putting this kind of effort into drilling down into what patients actually need from their acute visit to the hospital. Is the emergency department the best place for which of these evaluations? It's hard to say. Obviously, it's going to take time and effort and resources, and the emergency department is, as usual, everything to everyone. It's an interesting idea.
No, I think it's an interesting area, and the more social support we can give patients, the easier it is going to be to send them home. It always comes down to the same question, which is the resources we have to invest in this. Is it worth the results we're getting? This study in and of itself doesn't tell us that.
And then worth is also measured differently depending on whose perception is. I'm sure it's worth a lot to the patient to have this, but it's is there a zero sum game being played at the hospital and the department level? In any event, interesting. But if you are excited about doing more research into these sorts of things, then you can look at the next article in this issue called "The Development of a Unified Geriatric Emergency Department Database, 2022." The lead author here is Daria Herzovicki, and they're at Massachusetts General Hospital. And this is an article of interest to those engaged in geriatric emergency department research because, well, it does some work to create the best possible database of geriatric emergency departments in the United States. Specifically, it looks at those that are members of the Geriatric ED Collaborative, GEDIC, or accredited by the Geriatric ED Accreditation, GEDA. And it also investigates so-called age-friendly health systems. In the end, it finds that by 2022, there were 5,298 non-geriatric emergency departments and 324 meeting their definition of geriatric emergency department. An additional 202 were noted to be potentially geriatric emergency departments due to their association with age-friendly health systems, but these were still treated separately due to differences in certification standards. Nearly all geriatric emergency departments were in urban areas, were scattered across the country, and most were at stroke centers. The authors primarily use this article to note the small but increasing number of departments holding a certification in geriatric medicine, and to encourage both increasing the numbers of certified EDs as well as ongoing formal investigations of the influence of certification on patient-oriented outcomes, kind of like the study we just heard about.
Yeah, I mean, the big thing there is probably the research on whether these certifications actually improve outcomes, right? Because encouraging people to become certified geriatric emergency departments is all well and good, but as we talked about before, it's a zero-sum game, and so does this really benefit the patients? And I think that's still unclear.
So many certifications, so many online learning modules.
Well, that's the goal, right? Just to have more online learning modules. It's the dream in healthcare. All right, let's move on. Our next article, multiple healthcare encounters prior to the diagnosis of cerebral venous thrombosis. The lead author here is Lily Zhao, and this is the University of British Columbia. So CVT is a fairly difficult diagnosis to make. This is the pulmonary embolism of the brain, but the symptoms are vague and all over the place. You can have focal deficits, but sometimes they're absent. The patients are younger than normal stroke patients. It doesn't really fit any real template that we're typically looking at. Often they just have a headache. And so these patients, at least theoretically, often present to the emergency department a number of times before the diagnosis is made. And so what these authors want to look at is how often did they get to the emergency department before the diagnosis was made, and do these delays actually matter as far as outcomes go? So this was a secondary analysis of prior prospective trials, secret trial, and the top secret registry, which is a multi-center study that was initially intended to examine the effects of rivaroxaban versus standard anticoagulation for CVT. And so what they looked at this time was essentially patients who were diagnosed with CVT, either by CT or MR venography, and they looked at the number of health encounters they had prior to this diagnosis. Now, the important part, this was patient-reported healthcare encounters. And then they also looked at outcomes over the next 180 days, so modified Rankin scale and a number of different batteries looking at patients' quality of life. Overall, they had 102 patients. Median age was 45. 70% of the patients were women. Overall, the MRS, the modified Rankin scale, and functional outcomes were fairly good. So these were relatively mild disease as far as CVT goes. So 39% of the patients, or 40 out of 102 patients, had more than one healthcare encounter before the CVT was diagnosed as reported by the patient. The median time from symptom onset to diagnosis was 4 days. Of the missed encounters, 28 were presented to the emergency department prior to their diagnostic encounter, 20% to a family physician, and the remainder to a neurologist or other specialists. When you look at who was missed, women were missed nearly twice as likely as men. It was also more likely to be missed if you presented with a headache versus some other neurological symptoms. Obviously, not surprising. The thing that was actually the strongest predictor of getting diagnosed on your first encounter if you presented with a seizure, which again is unsurprising. Interestingly, the authors were unable to find that any delay to diagnosis was actually associated with worse outcomes. And so in some ways, that's comforting. I think there's a lot of limitations here. Obviously, it's a small sample size on a relatively mild group of CVTs. And so unclear in the sicker patients if these delays would have as little cost as it seems to be here. And then the other big thing here is this is obviously recall biased, right? This is just what the patients reported versus what was actually documented in the actual medical charts.
I just love that these are from the secret and top secret investigators. It's got a funny name for studies investigating cerebral venous thrombosis. But I think the key here is when it's obvious, it's obvious. And those patients get diagnosed relatively quickly. When it's less obvious, the patients, there's further delays in treatment. And it's a little bit hard to push this into context with the other literature because it does include, healthcare encounters with family doctors, neurologists, et cetera, et cetera. And I mean, for all we know, it could be an additional healthcare encounter can be, I saw my family doctor and they sent me to the emergency department, and that's 2 healthcare encounters. So you actually don't even know if they were like inappropriately or misdiagnosed by the initial healthcare encounter before subsequent healthcare encounters. That's not necessarily captured here. So, and then to be honest, there's probably a lot of headaches in the emergency department where we don't pick up a small cerebral venous thrombosis, and the patient just has the natural history of being fine. So I think it's one of these things where there's actually a lot more thrombosis out there that just spontaneously resolves with no sequelae, and we'll never know about it because we don't systematically scan every single headache with the level of detail necessary to find these little clots.
Yeah, or we start scanning more and more of them, and we start finding more and more of them, right? Could be similar to PE at some point, right?
They do great.
Yeah. I think the hard thing is it's a tricky diagnosis to identify. Like you said, when it's obvious, it's obvious. When it's not obvious, we tend to miss it. It's unclear if missing it actually has any clinical impact on the patient, or if they, when they come back and it's still there and we get it the second time, it doesn't really matter.
Yeah, I mean, if it's mild disease, does missing it matter? It's like the difference between a superficial venous thrombosis in your calf versus a deep venous thrombosis in your thigh. One of those is obviously more serious and requires immediate treatment. One of those requires, we're not sure exactly. It's not. It's a difference. It's a continuum of disease severity as well, I think.
I would say your brain is probably a little different than your calf, but
All right. Let's talk about the next little brief research report in this article issue called Individual Survey Items in Emergency Department Patient Experience Surveys Have Limited Ability to Distinguish Unique Aspects of Care. Funny, long title there with lead author Diane Kuhn at the Indiana University School of Medicine. But this article does have this. So this issue has this little brief report on one of our enduring favorites in emergency medicine, patient satisfaction surveys. We've previously covered reports where they find scores are tied to facility-related features, system issues, or even physician ethnicity. And this revisits that system issues in a similar way. These authors took the NRC Health Patient Experience Survey, a tool with 3 questions asked of all respondents and another 10 questions asked of subsets. They dichotomized the survey responses into quote-unquote top box responses or non-top box responses, which is either you only want to have, the top box responses, otherwise you're a terrible doctor. And they broke them down by question and then looked to see how they were related to various other ED visit features. NEDOC's crowding scores, placement in a hallway bed, emergency severity index, pain scores, laboratory studies, etc. The key analysis here, rather than focusing on any individual external influence on the scores themselves, was whether all the scores moved in unison or whether the individual responses were actually heterogeneous and potentially accurately reflected the underlying question. As in, did the external factor of being placed in a hallway bed affect an unrelated item like doctors and nurses consistent? The same way it affected a logical association like staff did everything possible for discomfort. And basically the answer is, well, every survey item moves in unison for the most part. If you were in pain on arrival, every score was diminished by virtually the same magnitude. If you had good relief from pain, every score was improved by virtually the same magnitude. If you were in a hallway bed, well, fewer patients in hallways, so less precise analysis. But again, all ratings worse by statistically similar amounts. So, just one more piece of the puzzle showing us these patient experience surveys are mostly invalid, useless instruments. And again, they certainly shouldn't be reliably attributed to individual clinicians.
Yeah, it's mostly what matters is out of our control as a clinician. All right.
You can put some effort into being abrasive and confrontational,
Yeah.
but otherwise, yes, it's mostly out of our control.
Let's look at our final article of the month. This is trends in non-research industry payments to emergency physicians between 2016 and 2020. And the lead author is Dalia Odwa from Henry Ford Health System in Detroit. We all know that industrial payments influence our prescribing and clinical decision-making. And so this study's basically asked what's been going on in emergency medicine over the past 8 years as far as pharmaceutical influences or industrial influences. And so what they did here was essentially looked at a cross-sectional analysis of CMS open payment data. It's publicly available from 2016 to 2023. They identified emergency physicians and they looked at non-research payments. So these are consulting fees, food and beverage, speaking, traveling, so on and so forth. They excluded one provider who received over $14 million because it was such an outlier. But I'd like to know who that provider was.
I have an idea.
And essentially, they just wanted to look at the proportion of emergency physicians receiving any industrial payments, and then what those payments were, in what form, and what specific drugs were driving these payments. So over this 8-year period, about 35% of the emergency departments, or 28,000 of the 80,000, receives at least one industrial payment over this time period. If you look, the proportion of payments in any given year fell from 16% in 2016 to 11% in 2023. But the actual amount of money that was invested stayed fairly steady throughout this period. So 9.8 million in 2016 to 10.1 million in 2023. And so what this means is fewer physicians are receiving these payments, but the physicians that are receiving them are receiving more money. And it looked like a lot of the stuff early on was food and beverage in the earlier years. And then as it kind of progressed through the years, it became more with high value consulting fees, so on and so forth over that time period. If you look at the drugs that were deriving these investments. In 2016, Xarelto seemed to dominate. Lokelma, the potassium binder, kind of took over in 2021 and 2022. Dexedit Alpha then started leading the way in 2022 and
Yeah, I mean, it's a little bit hard to put it into context because of the way that drugs kind of have a natural ebb and flow. It's not like emergency physicians are less receptive to non-research payments. Probably just there's all of a sudden everybody's already all of the things like Xarelto, the Pixabans and the Rivaroxabans are basically going generic, and they're no longer, or they've reached their maximum market penetration. They don't have to be marketed to emergency physicians to discharge them on this new drug for whatever it is, their DVT or their pulmonary embolism or what have you. And then, Dexanet will be gone now that it's no longer FDA approved in the United States. I don't know what's going to be left. It's going to be interesting to see what's next. I mean, no more payments from Altaplace, from Genentech. What are we going to find? So this is a obviously repeated study. 2016, 2023. What are we going to find in 2030? What's going to be the top drug in 2030? Do you think?
I'm sure we'll find something, right? There'll be something that's either, a newer version of an old drug that, works magically better as the old one fell off patent, or maybe some new antibiotics, so on and so forth. Overall, I think emergency physicians are one of probably the groups that gets far less of these consulting fees than many of the other more high paying or more influential spaces, but it's still something.
I wonder if they need to start, there's too bad there's no way of doing this for medical devices as easily, potentially for software as a medical device for all the new AI stuff that's coming out. That may end up being the big place where everybody starts to try and quote unquote cash in.
All right. Well, I think that wraps us up for another month. As always, any comments, questions, or concerns, we can be reached at annalsaudio@acep.org. Otherwise, until next month, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.